Արգելի գործընկերներ, սիրով ողջունում ենք ձեզ Հայկական
Dear
ակնաբուժության
colleagues, we would like to greet you for the Armenian Eye Care project.
ակնաբուժական կենտրոնի եւ Երևանի Պետական Բժշկական Համալսարանի
We would like to greet you on the seminars that were organized by ourselves, Armenian Eye Care Project, Malayan Medical Center, and the Department of the Yemen State Medical University. Dr. Armenia Garkishan, who is an assistant professor and Yemen State Medical University eye disease professor, she's joining us. She is also the neuro-ophthalmology and oculoplastics department, the head of the department. And from the US, Dr. Paul Johnson is joining us, ophthalmologist, and he is owning and he's the director of Paul Johnson Company. He's the only oculoplastic surgery from the trust, and this meeting will be a little different compared to our previous meetings because it will be more interactive, and Dr. Paul Johnson will present you clinical cases, and then you will have questions on your screens and you will have the answer options. And when you choose the answer, Dr. Johnson and Garkishan will be interpreting your responses. This is our first kind of experiment, and we hope that this will be fun and interesting, and we hope this will be interesting for both participants and professor. And now, please, Dr. Mr. Kisaran, thank you, and Armenian Eye Care Project. This is some news for us, and I hope that this will be a continuous experience. We would be happy to listen to Paul Johnson, and he has a very interesting presentation, very interesting cases, also including the discussions. And I would like to preserve your time, and doctor, please.
Dr. Paul Johnson, hi, how are you? We are so happy that we have this chance to hear you, and we are ready to start hear your lecture. Thank you very much.
Perfect. Thank you so much for that introduction. It's so nice to meet you guys. Today, I just want to thank you for your attendance and your participation. You could have been anywhere in the world today, but you're here learning about oculoplastics, so I appreciate that. Thank you so much. Today, we are going to go through a series of case studies, and then after each case study, there will be a multiple choice question. So that will give me feedback in terms of if this presentation is too easy, too difficult, or somewhere that's just right. So let's get started, and we can go to the first case right now. Perfect. So this first case is an 18-year-old man who had a sty that formed about a week ago. And over the past few days, the eyelid swelled up to this point. It's painful. What is the diagnosis? Is it preseptal cellulitis, chalazion, blepharitis, or all of the above? Perfect, perfect. So basically, the correct answer is A, preseptal cellulitis. So the majority of people got it right. Also, answer D could be correct too, because the preseptal cellulitis was caused by a chalazion, which was most likely caused by blepharitis. So good job, everyone. We can go on and to the next question, which is, what do we have to rule out? So I'll just give the answer to the question. The question is orbital cellulitis. From the last one, we have to rule out orbital cellulitis, and the treatment is oral antibiotics and warm compresses. So now we're moving on to the next case, which is a 37-year-old man with a history of sinus disease, and he's complaining of swelling, redness, pain, and double vision. What is the most likely diagnosis? Thyroid eye disease, idiopathic orbital inflammation, orbital cellulitis, or an orbital tumor? Okay, let's see. Yeah, perfect. So most people got it correct. It's orbital cellulitis. And Now we'll move on to the next question, which should be in the same case, but if not, I'll go through my other points for this case. So let's see if the next question comes up. Okay, so where should we send him? The correct answer is actually to the hospital for treatment. So answer D is the correct choice. Um, Question number 3, who should we call to help? Um, Whoever answered D was correct, so most people got that correctly. So it's otolaryngology and infectious disease. So otolaryngology can help with draining the sinuses, and usually this is a combined case with ear, nose, and throat and oculoplastics. And also we want to get infectious disease on board to weigh in regarding which type of antibiotics would be best helpful for this particular patient. And again, the last question, what should we start him on? The correct answer is C. So everyone got that one right. And that was IV antibiotics. Perfect. So now we can move on to the next case. Perfect. So for this next case, we got a CAT scan of the last patient, and this is what it showed. So you can see right here in this orbit. So what is the diagnosis? How do we treat it? And yeah, so we'll ask those two questions for this one. What is the diagnosis and how do we treat it? So the correct answer is B. So most people got that correct. Subperiosteal abscess. Specifically, I'm going to try to show it on the main screen. It's this area right here. You can see the abscess is below this lining, which is the periosteum. And how do we treat it? Yeah, most people got it right. So answer D, B or C, depending on the patient's age. So in kids up to age 10 to 12 or so, this is usually caused by one sole bacterium and usually responds quite well to IV antibiotics. However, in older patients, it's usually caused by more than one type of bacteria, in which case surgical drainage combined with IV antibiotics is the preferred treatment of choice. So let's go ahead to the next case. Beautiful. So this is a 49-year-old female. She's complaining of dryness, bulging eyes, achiness, and sensitivity to light. So what is the most likely diagnosis? What tests should we order? And what treatments can be used to help this patient? Beautiful. So thyroid eye disease is the correct answer. Answer choice B, most people got that. What test should we order? Most people got the correct answer for that, which is all of the above. So thyroid eye disease is made, it's a radiological diagnosis. So basically we always order the CAT scan to see the characteristic enlarged muscles on the orbital CT. We also want to order a thyroid stimulating immunoglobulin, which is answer choice B. That's very specific to thyroid eye. And it's always a good idea to get standard thyroid function tests as well to make sure that the patient's thyroid function is stable. And then the last question, how do we manage this? Pretty evenly split with our responses here. The correct answer is actually D, all of the above. So for mild thyroid eye disease in my practice, I can usually manage their symptoms with periocular steroid injections. I'll use a combination of dexamethasone and betamethasone to calm down any inflammation. For patients with moderate thyroid eye disease, so let's say they're having a little bit of double vision, or their symptoms are just a little bit more severe, I'll recommend Tepezza, which is done as an infusion, 8 separate infusions, spaced 3 weeks apart, which has shown so much promise in treating thyroid eye. And then the third option, if they require it, would be orbital strabismus and eyelid surgery. Although I have to say I'm doing a lot less of these types of surgeries nowadays with the help of Tepezza. Tepezza's really revolutionized treatment of thyroid eye. So at this point, we can go on to the next case. But if anyone has any questions at any point, feel free to stop me and we can, discuss a little bit further. Or we can go on to the next case, whichever you guys prefer. Okay, so this patient is a 6-year-old girl, and she had a bump in the outer part of her upper eyelid crease since birth. She recently fell on the playground, and the eye became very red. So, what is the most likely diagnosis? What test should we order? And how do we treat it? All right, let's take a look. Perfect. So only one person got the correct answer. It's actually answer choice D, which is a ruptured dermoid cyst. So she had had this bump since she was born, which would make rhabdomyosarcoma and dacryoadenitis less likely. So she had had this bump there. She fell on the playground, it ruptured and caused a characteristic inflammatory response in the superolateral orbit. Um, what test should we order? It's actually answer choice B, an orbital CT to make the diagnosis. And then the third question, the treatment of choice, the majority of people got the correct answer, which is surgical excision. Answer choice D. So the treatment for dermoid cyst is to surgically excise it. And then these patients tend to do really well after excision. It's something that we can actually cure in medicine, which feels good. So perfect. So let's move on to the next question. Great. So this case is a 50-year-old female, and she had painless proptosis of her left eye over the past several weeks. The CAT scan of the orbits revealed this lesion that you can see here. So what is the most likely diagnosis, and how do we treat it? So cavernous hemangioma, capillary hemangioma, fibrous histiocytoma, or plexiform neurofibroma. And then do we treat it with surgery, radiation, chemotherapy, or none of the above? All right, let's take a look. Perfect. So answer choice A is correct in this case. It's a cavernous hemangioma, which is the most common benign orbital tumor in adults. So we just did the most common benign orbital tumor in children. This is the most common benign orbital tumor in adults. And how do we treat it is actually answer choice A, which is surgery. In this case, we would do a surgery where we would remove the lateral orbital wall, part of the lateral orbital wall, to remove the tumor and then replace the lateral orbital wall using drills and screws and things like that. So a very extensive surgery, but again, another diagnosis in medicine that we could actually cure, which is great. So we can move on to the next case. So this is a 23-year-old man, and he got hit with a baseball, and he now complains of double vision and a sunken appearance to the eye. This is the CAT scan of his orbits. So what is the most likely diagnosis? Is it a ZMC fracture, an orbital fracture, a retrobulbar hemorrhage, or a lacerated inferior rectus muscle? Should we repair it? Yes or no? And how do we repair it? Do we use orbitotomy with microplates, orbitotomy with tissile glue, orbitotomy with orbital implant, or enucleation? All right, let's take a look. Okay, so the correct answer is actually answer choice B, which is orbital fracture. So you can see here that it looks like the bridge is out basically. The orbital floor has been fractured, and you can see this area is open. So there's an open communication between the orbit and the sinus. Um, should we repair it? Yes. Okay, 100% of people got that correct. Because the indications for repair are double vision, enophthalmos, that is cosmetically unacceptable to the patient, and a large fracture. So in this case, all three requirements are met for surgical repair, but you only need one of the three to make the decision to go ahead and repair the orbital fracture. And how do we repair it? The correct answer, most people got correct, which is answer choice C, orbitotomy with orbital implant. So basically, the orbit is approached surgically, it's opened, and an orbital implant is placed over that gap to sort of bridge that gap and restore the normal architecture of the orbit. So let's go ahead to the next question. Okay, so this is an imaging study for, or I should just say a diagram for a 31-year-old man. He was at a bar. He got into a fight and got punched on the right side of his face. He now has pain when he opens his mouth. So what is the diagnosis? Is it an orbital fracture, retrobulbar hemorrhage, a ZMC fracture, or a craniofacial disjunction? Should we repair it? Yes or no? And how do we repair it? Orbitotomy with tissue glue, orbitotomy with microplating, orbitotomy with orbital implant, or a facelift. All right, let's go ahead and take a look. Okay, great. Let's see. So yeah, so most people got this one correct. It's answer choice C, a ZMC fracture. And should we repair it? Yes. So if we look at the diagram, we can see that the fracture is in three locations. And this patient's having pain when he opens his mouth. So that's a condition known as trismus. And definitely we're going to want to repair it to help restore the normal architecture of his face and also to help with that symptom of trismus. And then question 3, how do we repair it? The correct answer is actually answer choice B, orbitotomy with microplating. So little microplates and little micro screws are used to reconstruct this patient. So let's go ahead to the next case. Okay, so this is a 51-year-old woman, and she was in a car accident, and her eye is now painful, bruised, and completely swollen shut. So what is the diagnosis? Again, her eye is completely swollen shut. Is it an orbital fracture, a ZMC fracture, orbital cellulitis, or a retrobulbar hemorrhage? Is this an emergency? Yes or no? How do we treat it? Do we drain it with eyelid incisions? Do we use ice packs? Do we use vitamin K? Or do we do a lateral canthotomy and cantholysis? And then what do we do? Do we send the patient home? Do we massage the orbit? Do we admit the patient to the hospital and administer IV steroids? Or do we send the patient home with oral antibiotics? Okay, let's take a look and see how we did. Perfect. Okay, so most people got the correct answer, which is letter D, retrobulbar hemorrhage. So the fact that the eye is completely swollen shut and cannot be opened is a classic sign of a retrobulbar hemorrhage. This is one of the few true emergencies in ophthalmology. Um, I've seen this, unfortunately, when I was on call for trauma call. I had one patient who had a retrobulbar hemorrhage after surgery for blepharoplasty, which thankfully I was able to get to the patient in time, and I performed the recommended treatment, which we're going to get to in a minute, to help save the patient's vision. So the patient was 2200 when I first saw him with an afferent pupillary defect and an intraocular pressure of 55. And then after treatment, he was restored to 20/20 and normal pressure and normal motility. So I'm very grateful that I was able to get to him in time. Is this an emergency? Yes, absolutely. This is an emergency. How do we treat it? So the correct answer is answer choice D, which is a lateral canthotomy and cantholysis. This is something I feel like every ER doctor should know and every ophthalmologist should know how to do. So basically what you do is you take lidocaine 2% with epinephrine and inject the lateral canthus with it. And then grasp the lateral canthus with forceps and cut using, I like to use a Westcott scissors, but if that's not available, a Stevens scissors also works well to cut laterally at the lateral canthus, and then grasp the inferior canthal tendon, strum the inferior canthal tendon with the scissors, and then snip across the lateral canthal tendon until you feel like a release. Like I call it like a blow for freedom. Like the eyelid is completely free and detached from the globe, at which point you can express, any blood that's in there to try to decompress the orbit because the orbit is extremely congested. And then the majority of people got the correct answer for the last question, which is what do we do next? So this patient should be admitted to the hospital and given IV steroids. And the IV steroids help with any congestion that remains after that procedure is done. And then, of course, this patient should be monitored very closely in the days following the trauma. Perfect. So let's go on to the next case. Wonderful. So this is a 62-year-old man, and he has an anophthalmic socket, as we can see. So why would someone need to have their eye removed? Would it be due to trauma, an intraocular tumor, a blind painful eye, or all of the above? How can an eye be removed? Should we use evisceration, enucleation, exenteration, or all of the above? What do we put in the socket? Do we put a prosthesis, an orbital implant, a conformer, or a tarsorrhaphy? And what else do we insert? A conformer, a prosthesis, TCL glue, or a gold weight? And when can the patient get fit for their prosthesis? So kind of revealed the answer on this one here, but can they get fit immediately the day after surgery, 1 month after surgery, 3 months after surgery, or 6 months after surgery? So several questions on the anophthalmic socket here, so take your time. All right, let's check the results. Okay, great. So why would someone need to have their eye removed? Most people got the correct answer, all of the above. So if there's been severe trauma and the eye has no light perception vision, the standard of care is to remove it to prevent sympathetic ophthalmia, which you guys probably know is uveitis in the contralateral eye. I did see one case of this in my career, quite fascinating actually. If they have an intraocular tumor, which is deemed malignant, or if the eye is blind and painful. And how can we remove an eye? So again, most people got this correct. The correct answer is all of the above. So evisceration is just removing the inner contents of the eye. Enucleation is removing the eye itself. And then exeneration is removing the eye and the surrounding soft tissues, and sometimes even part of the bone. Exeneration is used for only very severe invasive orbital tumors, fungal infections, things that threaten the life of the patient because it's very disfiguring. Enucleation can be used for an intraocular tumor. It should it can be used for trauma and blind painful eye. Evisceration really is the only time that that would be used for is for a blind painful eye. It should never be used for intraocular tumor or for trauma. And evisceration can also be used for endophthalmitis. So severe endophthalmitis causing NLP vision. So what do we put in the socket? The correct answer is B, an orbital implant. Perfect. So when we're removing the eye, the patient obviously loses volume in the socket. So we want to replace it with volume to restore natural appearance. And so an orbital implant is placed. What else do we insert? The correct answer here is actually answer choice A, which is a conformer. So conformer is sort of like a hard contact lens. So the orbital implant looks like a ball. I'll kind of show it like with my fist here. That goes in the orbit, and then we suture tenons and conjunctiva in front of the implant. And then the conformer kind of sits like this in the fornix. And then the eyelids are in front here. So the conformer basically holds the space open for the future prosthesis. And because there's a lot of swelling after this surgery, a tarsorrhaphy is then placed to make sure that the conformer doesn't fall out. And these patients can get fit for their prosthesis, answer choice C, about 3 months after surgery. So 3 months after surgery, more or less, all the swelling has calmed down at that point. And then they are referred to an artist called an ocularist who can design their prosthetic eye. So awesome work on that one. Let's go on to the next case. Beautiful. So we finished the orbit part of my talk, and now we're moving into the eyelid section. This is a 28-year-old man, and he has a history of blepharitis. This bump appeared a week ago and is painful. So what is the diagnosis? Do you guys think it's basal cell carcinoma, squamous cell, a chalazion, or an infected implant? Excuse me. And then how do we treat it? Warm compresses, steroid injection, excision, or all of the above? So just 2 questions on this one. So let's go ahead and check out the results. Brilliant. So most people got the correct answer, which is chalazion, answer choice C, given the history of blepharitis and the timing of it. So basal cell and squamous cell usually would develop a little bit more slowly. Chalazion usually comes in a little bit more rapidly. How do we treat it? Perfect. Okay, so most people got the correct answer, all of the above. We can start with warm compresses, and if that doesn't work, I often perform a steroid injection in the office. I'll inject, some people use Kenalog. I like to use dexamethasone or betamethasone, and oftentimes we can at least make the chalazion smaller, if not get it to go away completely, and then excision for anything residual. So great job on that one. Let's go to the next one. Perfect. So this is a 48-year-old woman with very itchy eyelids. So what is the diagnosis? Is it blepharitis, meibomianitis, dermatitis, or preseptal cellulitis? And then how can we treat it? With a steroid ointment, steroid injection, or excision with biopsy? Or answer choice D, all of the above is another option for that one. All right, let's check out the results. Perfect. So almost everybody got the correct answer here, which is dermatitis. So this can either be like atopic dermatitis, meaning the patient is reacting to something in the environment, or a contact dermatitis, where something is coming in contact with the eyelids, like a product that they might be using, or seborrheic dermatitis is another possibility. And the correct answer for number 2 is actually all of the above in this situation. So most people chose answer choice A, which is very reasonable to start with a steroid ointment. That's the standard of care. We want to start with like a Maxitrol, Tobradex, something that contains either just a pure steroid or a steroid in combination with an antibiotic. Most cases I can get under control using a steroid ointment. When that doesn't work, I will sometimes inject steroid to the affected eyelid if it's very severe. And then if it's still not responsive, I'll remove some of the extra skin. I'll do sort of like almost like a cosmetic blepharoplasty in these patients, and then send it to the lab for a biopsy to see, is there something that I'm missing? Is there like fungus involved? Is there, something strange, that's causing them not to respond to treatment? Um, Another option would be topical tacrolimus cream. Tends to work really well for this if the other options aren't working well. So. You guys are doing amazingly well. Let's go on to the next case. Beautiful. So this is a 57-year-old man, and he's saying that his eyelids rub against the pillow at bedtime, which causes irritation. So what is the diagnosis? Is it ptosis, dermatochalasis, floppy eyelid syndrome, or giant papillary conjunctivitis? What is this condition associated with? Is it diabetes, hypertension, hyperlipidemia, or sleep apnea? What test should they get? So should this patient get pulmonary function tests, a sleep study, an exercise stress test, or cardiac catheterization? And number 4, how do we treat them? We can do an excision of tarsal wedge. That's answer choice A. An external levator resection, answer choice B. A functional blepharoplasty, answer choice C. Or a lateral tarsal strip, answer choice D. And if they have ptosis, which surgery should be done first? Should the ptosis repair be done first? Or should correction of floppy eyelid syndrome be done first? So again, I kind of gave away the answer to some of the earlier questions with some of the later questions, but still a good starting point for our discussion of this patient. All right, let's go ahead and take a look at the results. Fantastic. So most people got the correct answer, floppy eyelid syndrome, answer choice C. So these patients classically will say that their eyelids rub against the pillow at bedtime, causing some irritation that's very frustrating for the patient. And what condition is it most commonly associated with? That's answer choice D. So most people got the correct answer there, sleep apnea. I would actually quote probably almost 100% link to sleep apnea in this situation. So if I see someone with floppy eyelid syndromes, it's almost certain that they have some degree of sleep apnea. So what test should they get? Letter B, sleep study. Perfect. Awesome work. So basically what I do is I refer them to their primary care doctor to help set up a sleep study to make sure that we're not missing any undiagnosed sleep apnea. And then the correct treatment for this situation is actually answer choice A, excision of tarsal wedge. So what I do is I actually remove a pentagon of tissue from the impacted eyelid and then sew the eyelid back together. So basically the pentagon, a full thickness wedge of the eyelid is removed, and then I suture the tarsus back together using dissolvable sutures like Vicryl, and then I reconstruct the lid margin and the skin wound using silk sutures. And then if they have ptosis, which surgery should be done first? So almost everyone got the correct answer. We're going to want to correct the floppy eyelid syndrome first, followed by performing the ptosis repair. And the reason for this is if we do the ptosis repair first without correcting the floppy eyelids, the results would be unpredictable, and we may wind up with an asymmetric result after correcting their ptosis. So awesome work, guys, on that one. You killed it on that one. That was great. Let's go to the next case. Beautiful. So this is a 39-year-old woman, and she noticed that this bump grew over the past several weeks. So answer or question 1, is it benign or malignant based on the photo? If you could venture a guess, I mean, we never really know for sure until we do biopsy, but if you could venture a guess, would you say it's benign or malignant? And how can we tell that clinically? Is it a lack of pigmentation, a small size, lack of symptoms, or no lash loss? So just 2 questions on this one. Let's go to the results. Perfect. 100%. Awesome. Got the answer. Benign. Perfect. Wonderful, wonderful. That's the correct answer. And how can we tell that it's benign? Most people got the correct answer, which is answer choice D, no lash loss. So skin cancer tends to kill the surrounding eyelashes. So in this case, if we look at the photo, all of her eyelashes are intact, which indicates that the lesion is most likely benign. Of course, we want to do a biopsy just to be sure. So awesome work. Let's move on to the next case. Great. So this is a 55-year-old woman with a bump that has grown over the past several weeks. Is it likely benign or malignant? That's question 1, benign or malignant. And then if the biopsy is positive, how do we treat it? Do we use frozen sections, Mohs, micrographic surgery, radiation therapy, or A or B? So answer choice D means we can either use answer choice A or answer choice B. All right, let's take a look. Only 2 questions on this one, so we can go straight to the results. Awesome. So malignant is the correct answer. We can tell by the lash loss here. So definitely some of the eyelashes are missing, which indicates that most likely this is malignant. This patient did wind up having a basal cell carcinoma. And the correct answer for the second question is D. So we can either use frozen sections or Mohs. So in frozen sections, basically, the tissue is removed and the specimens are frozen, and the pathologist analyzes the margins right then and there to say, you know, if they're clear or if they're positive. And once they're clear, we can go ahead and reconstruct. With Mohs, a same type of technique happens. So, you know, they say when the margins are clear, and then the patient is reconstructed, usually either later that day or the following day, or maybe 2 days later even. To reconstruct. So in that case, the patient has 2 surgeons, a Mohs surgeon and an oculoplastic surgeon working separately. With frozen sections, it's 1 surgeon. So the oculoplastic surgeon, you know, performs the frozen sections and then reconstructs immediately once the surgeon has the results. So frozen sections is kind of like one-stop shopping. Mohs is 2-stop shopping, but both have been shown to be wonderful treatments for these eyelid skin cancers. All right, let's move on to the next one. Okay, so this is a 23-year-old man, and he got hit with a bungee cord. So besides the eyelid laceration, what should we look for? Should we check for a ruptured globe, a canalicular laceration, a hyphema, or all of the above? And just 1 question on this one. So, all right, let's take a look and see. Okay, the correct answer is all of the above. Brilliant. So most people got it correct. So we're going to, anytime there's a trauma, you know, we want to make sure that the globe is intact, that there's no ruptured globe underlying this laceration. So we'll want to do like a Seidel test of anything that looks suspicious. We want to check for a canalicular laceration, although in this particular case, it's unlikely given the fact that the laceration is so far from the canaliculus, but still just something that we want to keep in mind for any lid laceration. We definitely want to look for hyphema, which is blood in the anterior chamber, to make sure that there's no hyphema there. So all of the above. All right, let's go to the next question. Perfect. So this is a 74-year-old woman, and she's complaining of tearing. So in this case, what is the diagnosis? Is it ectropion, entropion, blepharospasm, or hemifacial spasm? Which of the following, all right, so I kind of gave away the answer again in the second question, but which of the following is not a type of ectropion? So involutional, cicatricial, spastic, or paralytic. Again, which of these is not a type of ectropion? And then question 3, how do we repair it? an external levator resection, a functional blepharoplasty, a lateral tarsal strip, or Quickert sutures? All right, let's take a look and see. Perfect. So yeah, I figured everyone would get this one. Ectropion, where the eyelid is turning out, is the correct answer. And then which of the following is not a type of ectropion? Most people got the correct answer to that one too, which is letter C, spastic. Spastic is a type of entropion. But then for ectropion, we can have involutional ectropion or entropion. Cicatricial can go both ways too, ectropion or entropion. Again, spastic is just entropion, and paralytic is just ectropion. How do we repair it? The answers are pretty evenly split here, but most, or I should say, a large minority of the respondents got the answer correct, which is answer choice C, a lateral tarsal strip. So in this case, we're doing the opposite of what we did with the retrobulbar hemorrhage. We're tightening that lateral canthal tendon. So there's a canthotomy and cantholysis, just like for a retrobulbar hemorrhage. But then the lateral tarsal strip is horizontally shortened and then reapproximated to the periosteum of the lateral orbital wall to tighten up the lower eyelid. Great. And then getting word that we are going to do, I think, one more, and then we're going to stop there. And then, okay, perfect. So this will be our last one of the day, which makes me very sad. It's been fun doing this with you guys. So in this case, we have an 86-year-old woman, and she's complaining of tearing and pain. So what is the diagnosis? Is it ectropion, entropion, blepharospasm, or hemifacial spasm? How do we treat it? Do we use Quickert sutures, a lateral tarsal strip, a functional blepharoplasty, or both A and B? So answer choice D would be both Quickert sutures and a lateral tarsal strip. All right, let's take a look at the results. Beautiful. So almost everyone got the correct answer in this case, which is entropion. So the eyelid is turning inward, causing the eyelashes to poke the eye, and it's very, very uncomfortable condition. And then how do we treat it? Most people got the answer choice correct here, which is answer choice D. So we use a lateral tarsal strip in this case as well, just like the for ectropion. And then Quickert sutures can be used as well. So Quickert sutures are basically sutures that are passed into the inferior fornix to emerge just below the eyelashes where they're tied externally in order to rotate the lid away from the globe. And sometimes I'll use Quickert sutures alone without the lateral tarsal strip if the patient is too sick to undergo anesthesia or surgery, and they just need some relief immediately before we have time to set them up for a more extensive surgery. But then the definitive treatment to prevent it from coming back is the lateral tarsal strip. So thank you guys so much. It's been such a pleasure to be here, and we'll have to finish the rest on another time if you found this helpful. So thank you very, very much.
Thank you very much for this great presentation. It was actually very interesting, and this format that is going with the case and with the questions. Actually, we don't have teprotumumab, unfortunately, till in Armenia, and we hope that someday it will be available in our country also, as we have so many cases with thyroid eye disease. So maybe every day we are seeing this kind of patients. Actually, all the cases that were presented, that we see them every day in our oculoplastic practice. That's why your presentation was very, very important for us. Actually, we wait for next meeting with you, and we hope that we can organize so that the residents, all our residents, will be involved in this program, because you will agree with me that this is actually very important, not only for oculoplastic people, but also for the residents. So thank you very much again. And
I would like to thank the organizers, and we hope that we will be able to organize the second part of this meeting, and I hope that we'll be able to involve our residents as well. This was really interesting initiative, and for the first time, You know, it's always difficult to have the first time for everything, but we would be happy to involve our residents as well, and we would like to encourage our participants, because it was very important to see the participation of the people that joined us. I would like to thank Dr. Johnson. Thank you for the great work you've done, and I hope this will continue further, and not just in terms of oculoplasty, but also would like to involve other neurospecialties, and maybe this format may be used for their ground rounds as well. I would like to thank you again, and I hope that we'll meet again very, very soon.
Thank you very much.
Thank you so much. Thank you.